So I'm going to be speaking today about the California Alzheimer's Clinical Care Guideline, which was put together many years ago and updated in 2017 by many people who are actually in this room, and we did it actually in this building. Just a disclosure that I'll be mentioning off-label use of medications in this presentation, although the focus really is not on pharmacological care per se. So the outline of my talk, basically I'm going to give a rationale for the updated guidelines and some takeaway goals, and then I'm going to review the guidelines, some of the new policies and practice trends on one side, and actually you can find a copy of those guidelines in the left side of the folder. So I'm going to talk about both sides. One is new policies and practice trends, the other side is walking through the guideline. And I'm going to insert some implementation tips, and if we have time, hopefully at least one case, maybe two case examples. So again, for this talk is basically, if you take something away from here, I want you to be able to take away that the state of California has guidelines that we would hope that you will all be able to adopt, and much of which you've already heard today. This is an emphasis of some of the things that have already been stated today. And most importantly, some of the things we wanted to punctuate today are the importance of identifying and assessing who the caregiver is of the dementia patient and working with that person as the primary person to help you take care of the patient. Also to recognize that there are troublesome behaviors and behavioral symptoms, not just cognitive issues that come up in the context of dementia, and what we can do about them. And lastly, that you aren't alone in this. It's difficult, but to learn your community resources and make community connections, because it's really about the team that you put together to help you take care of every patient and their family. So first, the rationale for the update. This clinical care guideline was first put out in 1998 and has been subsequently revised in 2002 and 2008 before it was revised in 2017. And on the side that has more writing on it, I guess the one that's not split into sections, that addresses new scientific advice and improved clinical practice and changes in state and federal law, and we're going to review that just briefly. But there's a new emphasis on focusing on the patient and the family and the role of a care plan and documentation of that plan, and the role of community organizations for support, and importantly, recognizing diversity amongst dementia patients and their families, that everybody comes to this disease from a different perspective, and that you can't treat everybody the same way, that everybody has different feelings about what it means to have dementia and how they deal with that and what it means to them symbolically, and that as care providers, we have to meet them where they are and try to help them through that. And that also means trying to figure out what language they speak in, and trying to make sure that they understand what we're saying in a way that's respectful and that they can understand, and help them with a decision-making process that every patient and their family has to make when they're walking through this disease. So if you can see on the one side, there's been some new government policies that were put in place in between the last guideline and this guideline. First was the Medicare reimbursement, which has already been mentioned, but the CMS implemented the annual wellness visit that's to be done by primary care doctors every 12 months, and that provides for a question about whether there's a cognitive change. So that was, has already been spoken about, but that was a new change that we did not have before. Another thing was the adoption of the physician order for life-sustaining treatment, the POLST, which I'm sure many of you are familiar with in this room. Basically, it's a piece of paper that's bright pink that helps us, the patient and their families, just talk about what would they like for end of care. Do they want resuscitation and other things? And the guideline emphasizes that this will help patients and their families have more control over end-of-life care and preventing unwanted treatments, and reduce patient and family suffering. One of the other changes since the previous guideline was that the compassionate allowance benefit for early onset dementia, particularly in Alzheimer's disease, was adopted. This is a list where you can access your Social Security earlier. And previously, early onset dementias like early onset Alzheimer's and FTD had not been on this list, and now they are. So it's really great because a lot of these patients, particularly early onset patients, previously were working and sometimes are the primary income provider for their families. And with them not being able to work, this was really one more blow to the family. Not only does somebody have a cognitive problem, but they don't have a way to support their family. So being able to have these diseases put onto the compassionate allowance list was a great achievement. And lastly, that the CDC started the Healthy Brain Initiative, which basically the CDC mapped out a strategy for state and national partnerships to emphasize proven public health strategies, including policy development and monitoring, as well as evaluation and workforce competencies. The next section on the back is the emerging practice trends. First, that there's really been an emphasis in the past several years on earlier detection and diagnosis. And that's really the point, actually, of this care guideline and all of the things that we've talked about today, is that if somebody's coming in and they really have a memory problem that's really distinct, it's too late already. You know, we're trying to catch people much, much, much earlier on, not only because we know that that will get people into accessing care and support earlier, but one day we are going to have medications and we could start them earlier, and that would change everything. So we really need to help families and patients earlier. We also now have more of a recognition of mild cognitive impairment, which is not really a diagnosis, but it is sort of a description of the difference between having normal cognition and function and having dementia, which is basically abnormal cognition accompanied by a decline in function. This MCI is this middle ground, and it's not always due to neurodegenerative disease, but it can be, and it's what everybody's worried about. So it's really important to not let somebody walk out of the office if this is what you're worried about. We have to figure out why. Maybe it's reversible, and maybe it's not. Either way, somebody needs to get treatment and get the right support. The next big point is new evidence about antipsychotic medications and the FDA black box warning labels. This was actually put out in 2005, and I'm sure many people in this room are very much aware that both the typical and atypical antipsychotics have a black box warning. There is increased risk of cardiac and cerebral vascular events, particularly in the elderly. In its use for these medications are used many times for psychosis, and so there's been a real concern that people were just put on these medications and they're never taken off again. So there's really been a real push to reassess whether they really need to be on them. They do help, although meta-analyses show that there's no role individually. It does seem to help in certain cases, so it's important to evaluate when we use these and why we use these, considering that there is a black box warning. Next, as has been discussed previously, the guideline really points to gaps in disclosure and documentation. We know that there are patients that have cognitive difficulties or dementia, and it even might be in the chart and nobody's telling the patient and their family. And they are walking around for years wondering, what is wrong with mom? We don't understand it. We can't understand it. But it's even clear in the charts that people know, and they've been given the right medications, and nobody wants to say anything. And these poor families are walking around lost, and they're not getting the help they need. So it's really important that it's documented, the diagnosis is documented in the chart, so that everybody who ever sees that person can take care of them and their family. So that's one of the other things that the guideline really emphasizes. And lastly, the importance of lifestyle modifications. We know there are certain things in terms of dementia risk we can't change, right? We can't change that we're all getting older, and that's the primary risk factor for developing dementia. And the second is our genes, and we can't change that, but we can change many other things, and it's important to be able to tell all of our patients, hey, we need to exercise. You know, you got to watch your blood pressure, got to take care of diabetes. There's many things that can change the arc and change the risk of developing dementia as we get older. So now I'd like to address the front part of the guideline, and I'm going to walk through the various parts I'm not going to do it verbatim, but we are going to sort of just let you know what's there and sort of emphasize certain parts. So the guideline is split up into 4 different categories. The top is assessment. The next is care plan. The third is education and support. And lastly is important considerations. Okay? So the first is assessment. Understand or know the patient. And again, exactly what Josh said. Talk to the patient. Ask them, you know, what's going on. And it's really important to confirm and discuss the diagnosis with them. You do have to figure out where they are, right? We can't just blurt it out and say, hey, you've got Alzheimer's, and their jaw drops. I mean, obviously you have to do it in a sensitive way, but we really have to be telling people what's going on. And obviously it can be a scary thing to do as a care provider. You don't want to scare them. It's hard to give somebody a hard diagnosis, but we have to step up and do it. It's really important. It's also really important to, in the context of that, knowing what the person's culture is, what their values are. Not everybody's going to want to hear this information the same way, and different cultures see a different way. I think many cultures, dementia has a really bad connotation. You know, you're crazy. They think, oh, I'm crazy. And that makes them feel really bad or ashamed, or they don't want to talk about it. So we have to figure out how to understand, particularly in big cities like LA, right? So we have to figure out, understand who you're talking with, and make sure that we can respect their culture, and at the same time try to tell them what their diagnosis is. And especially we need to identify, again, the primary caregiver, and to assess the adequacy of what's going on in the family and their support systems. We know that caregivers of dementia patients are the primary people in the end who are going to be helping, as we just heard. They're the ones that are making most of the doctor's appointments. They are the ones who are actually, in the end, the people who are going to be the person who communicates on behalf of the patient when the patient can't make decisions or express their desires anymore. And so we know that we have to figure out who that primary provider is, whether it's a spouse or a son or a daughter or a good family friend who's devoted. But we have to know who that person is, because that's how you coordinate everything in terms of visits or what tests need to be done. And they're the ones, they need to know, you need to know who they are, so that when they call, you know who's talking to you, and that they know the patient well. So it's important to monitor and reassess changes. You have the annual well visit, and then every year or sooner, if it's every 6 months sometimes, we have to go over some of these things. So it's really important to annually evaluate people's instrumental activities of daily living, basic activities of daily living, their cognitive status, any changes in their medical conditions, because those things really do affect cognition. If somebody's sick and they're having diabetic fluctuations with glucose is out of control, or if they're getting a lot of urinary tract infections, we know that they're going to have changes in their cognition. We need to be able to assess people's emotional or behavioral or mood symptoms, the medications and supplements that they're taking, because obviously there are many medications that they should not be on. Like, for example, many of the medications that manage urinary incontinence, that can be very bad for cognition. And also evaluating home environment. If they're falling a lot, do we need to get a safety evaluation? Do we need somebody to go in the home and figure out, how to make the home safer? We also have to screen for abuse or neglect. This is just an example of what I use, and I'm sure many of you have some version of this. But these kinds of forms are very easily found on the internet and probably in the care program, and you can hand them to the patient's families when they're waiting to see you, so it doesn't take any time, so that when you see them, you already know what's going on. And this is just an example of the PHQ-9. Again, something really important to make sure we cover, whether somebody's feeling depressed or not, easily done, not on your time, but on the patient's time when they're waiting, so that when they come in to see you, you already have this information. Okay, so we're going to move on to the next section, which is the care plan and beneficial interventions. So first is disease management. So we need to discuss the progression and stages of the disease. It's really important. Now, sometimes a patient's family aren't going to be ready for everything at once, but you know the road that they're going to take, and you can sort of see it before they can sometimes. So it's important that we have to talk about the progression and evaluate and manage their comorbidities in the context of dementia and their prognosis. For example, we have patients that come in and they have sleep apnea, and they should be using a CPAP, which is already a hard thing to use anyway. But we have discussions, are we really going to push that CPAP, or are we not going to, right? You've got to figure out how much of this are you going to do or not, or how we're going to manage with people taking pills. How can we make it easier? Are there any pills that we could take apart that are allowed to be sprinkled instead of swallowing, these kinds of things. But the key thing here, and this is not the guideline, this is my comment. But communication is really key to a successful care plan. Again, we know that 50% of patients are not told their diagnosis, even if it's documented in the chart. It's really important to tell them what's going on. Maybe not the first time you see them, you can allude to it, and the second time, it's a conversation, it's a dance, it's a relationship. We know that active management improves quality of life for patients and their caregivers, and active management means that you're going to disclose a diagnosis, coordinate care amongst physicians and everybody else who's instrumental to the care team, the social workers and the therapists, lay caregivers. It's really important to empower the caregivers. They need to be educated about the disease, and they need to plan for the future. You can't plan in an emergency. You have to plan ahead. So we need to assess, just as Josh was saying, and as Dr. Rubin said, to assess where the patient and the caregiver are. I guess what was the phrase? I don't play golf. I can't come up with that quote. But where are they at? You know, feel out where the patient is in terms of dealing with the diagnosis. And what discussion do you think they're ready to have? What can they handle now? And what are you going to tell them later? Sometimes all they can hear is Alzheimer's disease or dementia, and you're going to leave it right there. And you're going to let it sit. And you're going to say, okay, you're going to come back and see me in a month. And you have to wait for it to just kind of settle. And then you can start talking about it. With each visit, you can give them more, right? Because sometimes the only thing that they hear is Alzheimer's, and you may have a list of things you want them to do, and they're at the checkout desk, and they didn't hear anything but that. And it's a shock. So figure out where they're at. Now, there's some people who come in, I don't know how, there's some people who are really great at it. These caregivers come in, they're partners, they're not even caregivers, they're partners at this point in time, and they're just somehow get it. And they're like, give us everything, we want to know everything right away. Well, then give it to them, right? So you have to figure out where they're at. But you have to map out an approach for how you're going to talk to people. Now, in terms of disease management, as we've already discussed, there are certain medications, and we do consider using acetylcholinesterase inhibitors and memantine, which is the only NMDA antagonist. The acetylcholinesterase inhibitors are donepezil, galantamine, and rivastigmine. Donepezil is approved for all the way from mild, moderate, and severe dementia. Galantamine and rivastigmine for mild to moderate dementia. Memantine is approved for moderate into severe dementia, and then Nimzaric is this new combination that came out in 2014 to make things simpler because it's one pill, but it's the same stuff. And I'm not going to go into today the data for this, but this is what we have. It may help. It's not like blood pressure medications where you get a distinct change. And so we offer this. I don't jump up and down if patients say they don't want to take it. If they do want to take it, I'm like, great, let's try it. If they don't want to do it, it's okay. All right. What else is part of the care plan? So you need to promote and refer people to social services and community support. And it's really important to remember you're not alone. Taking care of dementia patients requires a team, and there are services available in the community to help you, and that's the key. In terms of addressing emotional and behavioral and mood symptoms, we know that this is part of the disease process. Sometimes it's the first sign. Maybe cognition is not the first thing. Maybe it's not memory. Maybe it's really that somebody's becoming more irritable or they're developing depression, and that's the harbinger to what's coming, actually, that there are going to be cognitive changes. And sometimes it's the cognitive changes and then there's depression later. It's really hard to know, but it's definitely part of all dementia processes, and it's imperative to deal with it as much as it is to deal with medical things or other things like diabetes and hypertension, which is pretty standard as part of primary care practice. So in terms of the guidelines, it's recommended that we first consider non-pharmacological treatment, and that means counseling either the patient or the family or both, changing the environment, making tasks simpler. For example, if people are getting really frustrated in terms of handling a lot of things. A lot of times caregivers say, well, I don't want to give the person less. I don't want them to get lazy or think, but no, it's not that, right? They're not going to get weaker because, maybe they just can't do it anymore. So now they're getting frustrated. We need to change how to still empower them, but not give them as much, they don't have to remember 10 things on a list to do. And caregiver training is really, really important because it helps caregivers reset their expectations and the expectations of their loved one that they're helping, and it helps them know what to expect. It's really important also to consult with or refer to mental health professionals when needed. So we always recommend, again, non-pharmacological approaches first, like redirecting a patient if they're getting irritated, other things like that, using music to help calm people. But if that doesn't work, there are medications targeted, but it should be targeted, right? Not just blanket use. So we should use medications in a targeted way, depending on what the behavioral change is. And again, I've already talked about there's the FDA black box warning on antipsychotics. But for targeted symptoms, for example, for anxiety, we should use an SSRI, not benzodiazepines, which is, it seems to be used all over the place, but benzodiazepines are not good cognitively, and it definitely puts people at risk for being somnolent all day, and it puts them at risk for falls, and actually is worse for cognition in the long run. For depression, again, using an SSRI or SNRI or bupropion. Sometimes for agitation, we actually try an SSRI or memantine or trazodone or even Neurontin, that's off-label. And then acetylcholinesterase inhibitors for some of these behavioral changes, which seem psychotic, but really it's part of the disease. So it's particularly for Lewy body dementia, visual hallucinations and delusions sometimes respond really well to acetylcholinesterase inhibitor. You don't need to use an antipsychotic. So when do we use the antipsychotics then? So we use it when there's a need to take care of the patient, and what's happening is that you can't, or the patient's family can't, because they're so agitated that either they're putting themselves at risk or in harm's way, or the caregiver in harm's way. They're worried about, because of violence or significant irritation, they can't take care of them. It's in those cases when we consider using these medications, and specifically really for delusions that are so harmful that, say, if they're not eating, right, because they're really afraid that their food is poisoned. We've had that happen before, and acetylcholinesterase didn't help, right? We couldn't get it to work. That didn't help, first pass. So they're not eating because they're sure that someone's poisoning their food. Or visual hallucinations where it's really getting in the way. Again, as Josh mentioned, the woman in the polka dot dress, I have people who have seen monkeys in the trees or kids playing outside, or that's okay. If it doesn't bother them, you don't really have to treat it. But if it's bothering them, then you have to treat it, because it's going to get in the way of their quality of life or being able to help take care of them. And agitation and aggression, again, that's where you want to use these medications, but carefully, because again, there's a black box warning. So whenever I use these and I'm considering it, I have to have a conversation with the patient, and really at most times caregiver, and say, okay, here's the situation. I think we have to consider this, but here's what you need to know. There's this risk, right? And we do weigh out the pros and cons. Right now you can't take care of them, so maybe this medication is going to outweigh, this potential con. But it's really important, and it's important to revisit it, because they don't necessarily need to be on these medications forever. So you have to consider tapering them off at some point once things quiet down, and people go through phases. You don't always need to be on these forever. And there's other cautions aside from the cardiovascular and cerebrovascular risks, so people can be really somnolent on some of these medications, like quetiapine or risperidone. They get somnolent. Sometimes they develop Parkinsonism, which puts them at risk for falls. So you have to be really careful. All right, so another part of the care plan, the guideline, is to evaluate safety issues. So we do need to discuss driving, wandering, firearms, fire hazards, and recommend medical identifications for people who wander, like the safe return bracelet. And we'll talk about driving in a little bit later. And then, of course, documenting the goals of care, because communicating the care plan is important, as we've said already, so that when this person lands in the ER, everybody understands what's going on with them. They can't explain it to you, but the care plan, it'll state, what's the state of this person and what was the plan for them. It's also really important to explore the preferred intensity of care, like palliative care and end-of-life options, and to have that documented. These days we have electronic health records where you can just put all that in. So I know at UCLA we have a special tab for that, right, where we put everything in that's just that. And it's really important to provide information and education on advanced healthcare directives and the POLST and DNR orders and power of attorney. Lastly, we need to promote healthy living. So again, what I already talked about, but it's really important to talk to people about modifiable risk factors. I don't know how many times a day I talk about the importance of exercising. And then I regrettably think about how I'm sitting in my office and not getting to exercise. It's killing me. So, but it's really important to let people know this is not completely out of their control and there's something they can do about it and they should feel good about it and they can be empowered. They need to go eat healthily. They need to go exercise. The rats, the mice, they all had improvement in their memory, and so can we. All right. Lastly is to refer to clinical trials. So if interested, the guidelines recommend advising patients and family of their opportunities. And I would say, as somebody who also does clinical trials, that, and as somebody who didn't know much about them before I started doing them, it's not something that people know about, and it's not even something that they think that they should know about, and they don't often come. I would say that maybe 5% of people that come to my office come in saying, I want to be in a clinical trial. And it's not the conversation that you have the first time you meet them, right? Because unless they're really interested, you have to develop a relationship. But there's a lot of clinical trials, and we're not going to get any further in terms of getting to a drug, and until we can get people involved in clinical trials. So it's really important to offer that as an option. And a lot of times families and patients don't know where to even get that information. So the California Alzheimer's Disease Centers, there's 10 of us across the country, all located at academic centers. That's one good place to look, or clinicaltrials.gov, which is online, or the local Alzheimer's organizations in your areas all have information about what's reliable. Where's a reliable place that you can screen for a clinical trial. Okay, so education and support, engage with the community. That's the third section of the guideline. And I really like this quote. What a medical provider should do is prescribe something that would give you the opportunity to learn about Alzheimer's and have interactions with others. That would probably be the biggest help. What I take away from this is really what I feel like I do in my office a lot of the time. I mean, I'm a neurologist and I am sitting there trying to figure out, do they have a cognitive problem? If they do, what is it? And I do the whole medical workup. And I can tell you, after we get to that, it's like I'm no longer, it doesn't matter, if I'm an MD, it's all other stuff. It's social support, and it's directing people, and it's very little medicine, really. Honestly, I feel like I should have gotten a social work degree. And really, that's what it is. And even if you think, I think that, we feel as physicians that we should be giving a pill but it's neurodegenerative disease, I don't have anything for you, there's nothing else I can do for you. Not true. It's never true. There's always something that can be done, and it really doesn't have to be pharmacological at all. And that's what patients and their families are looking for. And they do turn to an MD or another provider for that. So it's really important that as providers we engage with the community, because that's who's going to help us with these patients. And it's really important to communicate to the patient, the family, that they need to learn and how we're going to help them get the services that they need. So the first part of the guideline is to involve the patient directly in care planning, as we were talking about before. Don't just talk to, the minute a diagnosis comes out, you still have to talk to the person who's having the memory problem. They can understand a lot of times. So you really need to talk to them and to ask them, what do they want? And it's really important about talking about treatment decisions and giving them the referrals. And as the disease progresses, that conversation is going to change. And what you're going to suggest to the patient and their family is going to change in terms of what's appropriate and what's available to them in the community. But you want to link them to organizations that are culturally appropriate. And with it being LA, we have a lot of really great resources, in the different communities, Koreatown and in Sawtelle. There's lots of really great community neighborhood community centers where you can find activities in somebody's native language, which is really wonderful. So in terms of the state, the California Department of Public Health Alzheimer's Disease Program has a webpage, and I've included the information here. So that's a place within the state that you can start for getting information. And within our local community, and this list is not exhaustive, but there are the academic state-funded Alzheimer's disease centers. UCLA is one, USC has two, at Rancho Los Amigos and at the main campus. your local Alzheimer's organization has information. There's various community organizations. Again, this is just a couple. Jewish Family Services, Partners in Care, Betzedek has legal services that's around here, and local community programs. Again, the one that we use often are Wise and Healthy Aging and One Generation, OPICA, Senior Care Network, Lisa's Place, and the list goes on and on. So partly what you can do is try to build up, get a list, or talk to your local Alzheimer's organization and get a list from them, or just refer them, your patients, and they will help you so that you can get your patients to these organizations. It's also really important, and I think it's been alluded to a lot this morning, but it's not just the patient, it's the caregiver. It is really hard to be a caregiver. It's exhausting. And we know from studies, they have a higher rate of depression than other types of caregivers. They have medical problems that crop up because of the toll that it takes to take care of other people. So we really have to be looking out for them and take care of them too. And that might mean that they need care management, psychoeducational help, actual counseling, referral to support groups, respite help, psychotherapeutic therapy, or any combination of the above. But it's really important that when the patient comes every time, you're also asking the caregiver, how are you? It's really important, and many people don't want to say, or like, no, I'm okay, and everybody thinks they can do it themselves, but it's really hard. And they're there for the duration. It's really hard to do this for a long time, so you really have to look out for the caregivers too. There are many organizations, this is one example from Alzheimer's Greater LA, that there are care tips, just a little thing to give the caregiver to help them out in multiple topics on various languages that are available on the web. And specifically, one of the programs that Alzheimer's Greater LA has that I have used is the Direct Connect referral program that any physician can easily use, or any primary care provider. Basically, you can download this from the web and fill it out with the patient. You put in the patient's information and contact, and then the physician's contact, and then there's a list you can check off what you need help with. So if you need to find adult daycare support, if you need to find support groups, whatever, you check it all off. It goes to a social worker, and they will reach out to the family and help connect them with services. And then as the provider, they will give you feedback and let you know what was done, so that at least if you don't have a social worker in your clinic, you're going to have access through this mechanism. All right, last part of the guideline is important considerations. So time-sensitive issues, advanced planning. So it's really important to discuss basic legal and financial planning. And I've given some information there about how to find it. But again, even if you don't have time to have this conversation, the most important thing is knowing how to refer the patient to get this kind of conversation, right? So how to get them to a social worker to have the conversation. Capacity evaluations. Sometimes it's hard to figure out if somebody really has capacity. Do they have decision-making capacity, and maybe you don't feel comfortable trying to make that decision? Or maybe, it takes two physicians to declare somebody to not have capacity. But if you feel uncomfortable about doing it, there are psychologists and there's psychiatrists in the community who can help make that determination. You can send them for testing. But it's really important, and also to consider, again, literacy and language and culture in assessing capacity, right? Elder abuse. So we need to monitor for elder abuse, because we know that people, particularly if their memory is failing and their judgment is failing, they're getting taken advantage of. People taking people into their houses. So it's very important. Be careful, and we need to screen. Also, looking every once in a while, it's very sad, but a family member taking advantage of somebody. So it's important to report people to Adult Protective Services or long-term care ombudsman to keep people safe. Okay, so driving is like the dreaded conversation here. But California is a mandatory reporting state. So we have to, as providers, we do need to report. And it does put you at odds with the person you're trying to help. Kind of stinks. But we really have to do it. But luckily now there's GoGo Grandparent and other services that can help make it a little bit easier to get around than it used to be. So basically we have to report dementia. So basically you have to type in, if you just go to your browser and type confidential morbidity report and whatever county you're from, then it will pop up the appropriate sheet. The different reporting forms they're a little bit different from county to county. This is just the top part of the LA County, and just I put a red box around here. Note that this form is not intended for STD, HIV, AIDS, or TB. So they do have two different forms. So there's one where you can report lapses of consciousness, which is what dementia is. Lapse of consciousness. And then there's ones for STDs and things like that. So just be careful that you send it in on the right form. But you fax it in, and then the patient will undergo a driving test. And when I do this and I talk to people, I just tell them, look, we have to reevaluate. We want you to be safe. We want everybody to be safe. And just because you have a diagnosis of Alzheimer's disease doesn't necessarily mean they're actually going to take your license away. Right? They have to do an assessment, but you're going to get a test, you're going to get a chance. And even if I think the person should not be able to do it, I want them to go through the process, and I want them to officially fail, right? It's hard, but sometimes they need to officially fail and not have their family member nagging them that they shouldn't be driving. Again, just trying to educate people about their eligibility for benefits. And honestly, I can say as a physician, I'm not great at knowing all this, but that's why you have resources and other people that you should know that can help you do this. But especially for people, again, who have early onset dementia, now that we have the Social Security Compassionate Allowance, it's really great. And there's other benefits that patients might be eligible for if they're veterans. And they may have long-term care. So it's important just to refer them to a social worker. There are services in your community that can help them have these discussions. So I have two cases, but we're just going to go through one of them, and we're going to go through the second one, not the first. So just to give you an example of walking through and using some of the aspects of the guideline to apply to a case. So this was a patient of mine, a 72-year-old woman who came in accompanied by her daughter. She had a history of hypertension, chronic atrial fibrillation, which was rate controlled, and depression. And she had been diagnosed on the East Coast with dementia with Lewy bodies, and she had had significant agitation and delusions in the past. So she was on rivastigmine and multiple antidepressants and quetiapine, which is an antipsychotic. And then she had just moved to LA because her family had realized she really wasn't doing so well living on her own on the coast, and so she moved to be with her daughter. So now she was living with her daughter. And they needed to establish medical care, and her daughter was really seeking support because now that her mom was living with her, she was seeing the full amount of what her mom was really having trouble with, even though she knew, which was why she'd had her come out. So my workup, as part of what I was doing, I did my assessment and reviewed all the outside workup. I did my own smaller cognitive evaluation, neurological evaluation, and I felt, you know what, I agree with this diagnosis. It seems like Lewy body to me. And there were no red flags on exam. So her Parkinsonism was minimal, so that's good because, I'm worried about falls. Visual hallucinations were not causing a problem. They had been in the past, but it seems like the medication she was on, it was okay now, and she was sleeping okay. Her MoCA was 17 out of 30, so she's definitely cognitively compromised, but she was definitely participating in that visit. I was asking her questions, and she was giving me her opinions on things, so she was part of this whole conversation. She was definitely in favor of having moved to be closer to her daughter, and she knew, that she was having some difficulties. Although, probably a little bit lack of insight of how capable she was, but she definitely was still part of this conversation. So what were my concerns? Well, first of all, she had a significant history of depression, and so she was on lamotrigine and mirtazapine and bupropion. So I, as the neurologist, said, okay, this is a little bit more than I think I can manage, and I don't know, some primary care providers might feel good about it, but I think this is over my head. I'm going to have to get a geriatric psychiatrist. That's one thing I'm going to have to do. Also, she had a history of agitation in the past requiring quetiapine. Seemed like everything was good now, but make a note, going to have to reassess this periodically and make sure, again, is she too Parkinsonian? Is she having any falls that could be contributing because already DLB, they're already at risk for falls and Parkinsonism anyway. Third thing, she can't live on her own. She definitely had instrumental activity of daily living difficulties, but she didn't have great insight on this. And I caught that on that sheet that I showed you at the very beginning. And lastly, that the daughter was completely overwhelmed. She needed guidance for behavioral management, finding services. She was really worried about financial planning. So it was clear, like, here it is, here's mom. Oh my gosh, what am I going to do? So what was my plan? So for medications, no changes. I tried to hook her up with geriatricians, gave her a list, said, any of these are good. Get an appointment. Referral to geri psychiatrist, safe return bracelet, because her mom is still taking walks during the day when she goes to work, when this daughter's going to work. And then I made a bunch of referrals. So the first one was to Alzheimer's Greater LA for Direct Connect, and I checked off financial, future care paperwork, support groups, behavioral management, day programs. So at least I knew that I could connect her quickly to something. I also happen to know the name of an independent referral service that assists with finding assisted living facilities, which actually I didn't really know. It's because I'm friends with the Dementia Care Program, and they know. So I called and got a name. And then lastly, I did refer them to the UCLA Dementia Care Program, which has really been fantastic to help us. But they have a wait list because now everybody knows how great they are, and I can't, we have to get in line. So I tell the families, you're going to get in, you just have to wait, and in the meantime, this is what we're going to do, okay? Then I, of course, recommended exercise, healthy diet, and try to get her mom sort of hooked up with a new social community and activities. Okay, so visit 2, what had happened? They got a geriatrician. They had actually got lucky. They got into the dementia care program quick. And now I felt good because now I have a geriatrician on my team. I've got a dementia care nurse, and everybody's now starting to make this care plan. And it's getting documented in the chart, and everybody knows we're following the meds, we're assessing the patient's needs from every point of view, medical, social, financial. And a care plan has now been more established. The daughter was able to get help in the home. It's 3 days a week. The other 2 days a week, she's going to Wise and Healthy Aging. But now there's a new concern. There's a 2-hour gap between when the patient is at home and the caregiver or the assistant leaves or she comes home from the program, and when her daughter gets home from work. And she can tell that her mom's not doing as well as she used to be able to. So now she's still worried, how's she going to cover these 2 hours? We have to change the plan again. She's noticing her mom's having more falls. And then she'd also had a recent admission to the hospital for pneumonia. And that had really thrown her mom off because now she was really cloudier than she used to be. And with DLB, you're really cloudy anyway, so this didn't help. And her mom was getting better, but she had not gotten back to her baseline yet. So we talked a lot about what happens when you are medically ill, but you already have dementia, and how long that takes, and whether you'll really get back to your baseline from before. And she had started talking to her mom about moving to an assisted living facility because, frankly, she's a working person. She's young, the daughter, fairly young, and she can't do this at home. It's really hard. But her mom really doesn't want to have this conversation, and every time they do, her mom has like a nervous, she gets irritable, and she's really anxious, and it doesn't go anywhere. So what's the plan? Again, I'm not changing any meds. It sounds like there's all these other things that need to be going on, and the medications are fine. We're going to leave them alone. So we talked a lot, reassuring her daughter about the confusion after a medical illness and how long that's going to take. Again, she hadn't had time to do the safe return bracelet. Talked about it again. Reviewed fall precautions, and talked about, well, if your mom's going to stay at home, we need a home safety evaluation. And in the meantime, she can do physical therapy, gait and balance training. We also talked about, okay, let's think about other ways we can have the conversation about assisted living, and then to follow up with the geriatrician and the dementia care program, because this is really a space where these conversations happen. It's not always going to happen with me, but it's going to happen with these other resources that she now is hooked into. So, and I could see from the nursing notes, that they are also working with her on, hey, you got to get your mom to a geri psychiatrist. We've got to establish care, and we're going to work with you to find more care in the home if that's what you need, and to give the daughter herself support. So if you are looking for assistance, there are 10 California Alzheimer's disease centers who would be happy to assess patients and give advice in any sort of way in terms of how to medically manage a patient or anything else you need. There's 10 in total, 5 in Southern California and 5 in Northern California. We all work independently, but also together as a group on certain projects, and I've included the link there. And with that, I'll say thanks very much for your time.